Hello, I'm Sarah Hurvitz. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for today's educational activity titled Targeted Therapy for HER2 and HER3 Positive Breast Cancer, Navigating the Evolving Treatment Landscape. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. As I mentioned, I am Sarah Hurvitz, Professor of Medicine at the University of California, Los Angeles, co-director of the Santa Monica UCLA Outpatient Oncology Practices, and medical director of the Clinical Research Unit at the Johnson Comprehensive Cancer Center. Let me introduce our faculty joining me today. Let me first welcome my colleague, Shanu Modi. She is an associate professor of medicine, Department of Medicine, Weill Cornell Medical College. She's associate member, section head, HER2 positive breast cancer of the Breast Medicine Service at Memorial Sloan Kettering Cancer Center in New York, New York. Welcome, Shanu, and thank you for joining us today.
Hi, Sarah. It's great to be here.
I'd also like to introduce my colleague, Michael Press. Michael is professor, Department of Pathology, and Harold E. Lee Chair in Cancer Research at the Norris Comprehensive Cancer Center, Keck School of Medicine at the University of Southern California, just across the road from me. Thank you for being here today, Michael. Welcome.
Thank you. Thank you for having me.
So now let's turn to our learning objectives. The first learning objective is to apply HER2 testing guidelines for improved treatment selection in breast cancer. Our second objective is to evaluate clinical trial data for novel and emerging therapies for the management of patients with HER2 low expressing breast cancer resistant to HER2-directed therapies and HER3 positive breast cancer. And our final learning objective is to expand the use of telemedicine in breast cancer care, very relevant today in the COVID era. So now let's start by discussing how to determine HER2 status to guide treatment. Michael, this is an area with a lot of changes in the last 10 years. So can you start us off with a case first?
Yes, I can. Thank you, Sarah. So the first case for this evening or for today is the case of a 61-year-old woman with metastatic breast cancer. She was diagnosed on a left breast biopsy as having infiltrating ductal carcinoma in March of 2015, which was ER positive, PR positive, and it was reported to be HER2 positive, IHC3+ by immunohistochemistry. The HER2 FISH assay was reported to have a ratio of 2.3 with an average HER2 copy number of 3.8 and an average chromosome 17 centromere number of 1.6 per tumor cell. Subsequently, in September of 2019, she was diagnosed with metastatic carcinoma in pleural fluid. And although ER and PR were not provided to us, we were told from the outside hospital that the HER2 immunohistochemistry status was now scored as IHC2+, and the FISH assay, which had previously been considered to be positive, was now considered to be negative with an average HER2 copy number and an average chromosome 17 centromere copy number, each of 2. So the ratio was 1. So the patient, because of the discrepancy between the original biopsy result and the subsequent metastatic tumor, the patient was referred for consultation and for a second evaluation to our laboratory. And we received 2 samples separately, which we will discuss on the next slide. So in the initial left breast biopsy from March 2015, we were asked to perform both immunohistochemistry and FISH, and they're shown across the middle of the slide, beginning with the hematoxylin eosin stained sections, is a representative microscopic field, followed by 2 immunohistochemical assays and a FISH assay result that's illustrated. The FDA-approved OncoHercept test was scored as 2+. A laboratory-developed assay that we use in our laboratory routinely for each case was scored as 1+. And then the FISH assay was evaluated as having an average HER2 copy number of 2.5 per tumor cell. Chromosome 17 centromere average was 1.5 per tumor cell for a ratio less than 2. And the FISH ratio is illustrated with HER2 copies shown in red and chromosome 17 centromere signals shown in green. And this was assessed as HER2 not amplified with low expression. And the second sample that was advanced to us demonstrated metastatic carcinoma in the pleural fluid, as shown on the H&E tissue section with the tumor cells as illustrated. We were not requested to do the immunohistochemical assay, so we didn't use an FDA-approved assay, but we did run our laboratory-developed assay for 10H8, monoclonal antibody in the background, and we also performed the FISH assay on this tissue sample. The FISH assay had an average HER2 copy number of 2.8 and an average HER2 chromosome 17 centromere number per tumor cell of 2 for a ratio less than 2 of 1.43, and it was interpreted as HER2 not amplified with low expression of the products.
So, Michael, this is, an interesting case, but I can say I've actually seen it in my own practice before, where we initially think it's positive based on one testing, and then upon repeat testing of the new sample and repeat testing of the prior sample, we find out it's negative. Can you give us some clinical pearls from this case that are relevant to clinical practice? What are some take-homes?
One of the take-homes is that each one of these FDA-approved assays uses a different antibody to recognize HER2. The antigen retrieval conditions are slightly different, and the interpreter may be different from laboratory to laboratory. So there's going to be some variability in the immunohistochemical assay. I think the other thing to keep in mind is that the initial biopsy, which demonstrated both positivity, both by immunohistochemistry and FISH, you'll note that the average HER2 copy number was rather low. It was less than 4. And I think this is something to keep in mind when you have any questions about either of these assays, or they don't match your clinical expectation, to have a high level of suspicion and seek a second opinion.
Thank you. That's very helpful. And I think in the last decade or so, we've seen the evolution of guidelines for interpreting HER2 test results. I know you've been a part of those guidelines along the way, and I myself as a clinician has been confused at times by how to interpret and apply these guidelines. There are now 3 different subgroups that are considered to be indeterminate or borderline for FISH positivity. And so I'm hoping you can take us through now sort of an overview, how the tests were developed and how to interpret the guidelines that we now have today.
I'll try to briefly cover some of the points that are related to conceptualizing the HER2 testing. One of them is that HER2 gene amplification is directly correlated with HER2 overexpression, especially if you're looking at frozen tissues. Of course, clinical samples are formalin fixed and paraffin embedded these days. And I'll show you some data that we've generated in our laboratory that demonstrates that FISH is significantly more accurate than immunohistochemistry in these fixed paraffin embedded samples. I'll briefly summarize the high points of the guidelines for HER2 testing in breast cancer from 2007, 13, 14, and 2018. I'll talk about each one of the FISH groups that have been now characterized beginning in 2013 and 2014, and where their evaluation stands in the 2018 guidelines. And then finally, I'll just say a little bit about the equivocal probes that were used between 2013, 2014, up until very recently, and created, I think, some confusion within the field. So this is a summary slide to summarize data from a study that we did in collaboration with Dennis Slayman some years ago, quite a few years ago. And it was a study of frozen breast cancer samples that were analyzed at the DNA level for HER2 gene amplification by southern blotting, at the RNA level for HER2 expression by northern blotting, and then the protein product was characterized by both Western immunoblotting and frozen section immunohistochemistry. And this slide demonstrates the results of that, some of the results of that study. The HER2 amplification was determined when the HER2 signal compared to another gene on the same chromosome, myeloperoxidase. When the ratio between them was greater than or equal to 2, they were considered to be HER2 amplified breast cancers. When it was less than 2, it was considered to be not amplified. You'll note that as you progress from right to left across that series, there's a progressive increase in the amount of messenger RNA that's localized by northern blot, and in progressive increase in the amount of protein product that's present in those tumor samples from right to left with increasing amplification. Likewise, in the frozen section immunohistochemistry, there's also a progressive increase in the amount of immunohistochemical staining. There are a couple points that are worth noting as we look at these. One of them is that as you look at each one of these samples that's illustrated for the immunohistochemistry, they're remarkably similar to one another throughout the tumor cell population. There isn't a lot of variability in the staining. This is not only true of the field that's illustrated, but across the entire slide of these was very typical. You'll also note that for those cases that are not amplified, the 63% that did not have amplification and had low expression of the products of the HER2 gene, that product at the messenger RNA and at the protein level and by frozen sections were detectable throughout. So what we call IHC 0 in formalin-fixed paraffin embedded tissue, one needs to remember that this gene is still expressed at low levels. That really leaves us with one other category that were on that previous slide, characterized there were 10% of the samples that did not appear to have gene amplification by southern blotting, but nevertheless had overexpression of the messenger RNA and the protein. And on the following slide, it summarizes when we characterized those cases by FISH. On the next slide, we found in the lower right-hand corner, in red, you'll notice multiple signals in each blue tumor cell nuclei. These cases actually had gene amplification with overexpression, as illustrated by the immunohistochemistry above, that was not appreciated by southern blotting. These were primarily stromal-rich breast cancers where there was relatively little tumor cell extracted, and so this was considered a dilutional artifact of the method that we were using. So in summary, this indicates that there's a very close relationship between the gene and its products. When the gene's amplified, it's overexpressed. When it's not amplified, it's not overexpressed. And on the next slide, shows an example of when one has such molecularly characterized samples, one can use it to characterize and collects the formalin-fixed paraffin embedded tissue blocks. One can then use those blocks and the knowledge, the blinded knowledge of what the status is, to characterize assays that become available and are FDA approved. So this shows one of those studies that we conducted. Across the top series of panels that are illustrated, there are 6 panels illustrating the result from one breast cancer that was known to be amplified and overexpressed. The two left-hand side are FDA-approved assays that characterize gene amplification by FISH. One shows the HER2 signals in red, the other shows the HER2 signals in green. You'll notice all 4 of the immunohistochemical assay results are positive for membrane staining across that breast cancer. The lower example shows another amplified overexpressed breast cancer that's amplified in both FISH assays, but only one of the 4 immunohistochemical assays shows membrane staining. And if you look across the top, the concordance with known molecular status, the FISH assays were both correlated with 95% with the known HER2 or molecularly characterized status, whereas the 2 FDA-approved immunohistochemical assays approached 90% but didn't reach it. And this difference between over 95% and approximately 90% was statistically significant. And so we would argue this demonstrates significant higher accuracy for FISH compared to immunohistochemistry. And if we look at the next slide, this summarizes the approach that has been used in the ASCO-CAP guidelines. And I should also mention that I'm a member of those guidelines committees since 2006, by way of full disclosure. It shows the algorithm that was developed for scoring immunohistochemistry and testing in 2007 and in 2013, 2014. Each one of these guidelines, even up to 2018, accepts that immunohistochemistry could be used as a primary screening technique for HER2 status, and indicates, as shown in the middle bottom of the slide, that when the immunostaining is strongly positive, 3+ positive, these patients should be considered candidates for targeted therapy. And when it is weak or negative, 0 or 1+, the patient should not be considered for targeted therapy and should be considered low expressors. The intermediate group at IHC 2+ should be reflexed for FISH to characterize their status. One of the important differences between 2007 and 2013, 2014 is that one of the requirements in 2007 was that any laboratory using immunohistochemistry as a primary assay must demonstrate a 95% concordance or agreement rate between the immunohistochemistry categories that are going to be used, 0, 1+, 3+, and the FISH status that is determined by immunohistochemistry. This requirement was dropped in 2013 and 2014, and it was recommended that this would be at the lab's discretion to choose what agreement level was necessary. The next slide shows a series of studies that were published from 2008 to 2014. They're similar to the studies that came before 2008, where it was well recognized that there was considerable disagreement between immunohistochemical studies in different laboratories. And this data demonstrates that that remains true between 2008 and 2014. It shows the HER2 gene amplification rate as a percentage for each immunohistochemistry category among studies that had at least 100 or more breast cancers characterized by both immunohistochemistry and FISH, starting from an ideal result for IHC 0 would be an amplification rate of less than 5, likewise for 1+, less than 5%. And in the 3+ positive category, one would expect 95% amplification or greater. The red boxes indicate that these studies did not achieve that level of agreement. There are only 2 of these studies that actually have 95% agreement all the way across 0, 1+, and 3+, and the others do not. Subsequently, in the next slide, the category has remained, the approach to immunohistochemistry testing for HER2 has remained essentially unchanged. And this issue of both false negatives and false positives by immunohistochemistry has not been, in my opinion, adequately addressed at this time. The next slide shows the way in which HER2 testing by FISH has been approached beginning in the guidelines from 2013 and 2014. Initially, the ratio between HER2 and a control like chromosome 17 centromere, when that ratio was greater than 2, the FDA said we'll call those HER2 amplified, like we had in Southern blotting, and when it's less than 2, we'll call it negative. Subsequently, this was changed, and in 2013, 2014, they also considered the average HER2 copy number. And I'm going to refer to these as groups 1 through group 5, shown in red. So when the ratio is greater than 2 and the average HER2 copy number is greater than 4, these were to be considered ISH positive or group 1 and remain so in the 2018 guidelines. Among those that have a ratio greater than 2 and an average HER2 copy number per tumor cell less than 4, They were originally considered ISH positive and are now going to be further characterized by immunohistochemistry. I'll refer to these as group 2. Those cases that had an average ratio less than 2 and a copy number greater than 6 were originally considered ISH positive. We're calling these group 3. They also need immunohistochemistry at this time. Among those that have a ratio less than 2 and a copy number greater than 4 but less than 6 were considered ISH equivocal. We'll refer to them as group 4. They also require immunohistochemistry at this time for further resolution. The final group, group 5, are those with an average HER2 copy number less than 4 and a ratio less than 2, and they are considered negative. On the next slide, one of the issues that came up is that at the time when this was published in 2013 and 2014, there wasn't anything known about the distribution of these different FISH groups across a population of breast cancers. And so we published our data from 2 different sets. One had to do with a consultation practice. We used about 7,500 cases from the consultation practice and more than 10,000 cases that were available to us from screening for entry to clinical trials by the Cancer International Research Group. And in the red box are shown the categories 2, 3, and 4. And you'll notice that those categories are relatively less frequent, respectively less than 1%, less than 1%, and between 4 and 5% of breast cancers. So groups 1, the amplified cases that are considered overexpressors, represented about 18% in our consultation practice, and those that are HER2 not amplified, approximately 3/4 of the samples. And we'll briefly now deal with the resolution of those less frequent categories of 2 through 4. So in group 2, it's now recommended that one also perform immunohistochemistry. And so when immunohistochemistry is performed, as you see, if they're on the left side, IHC 0 or 1+, and I've introduced in black the percentages that we've seen in some of our studies. About 90% of the breast cancers from group 2 will fall into 0 or 1+ categories. IHC 2+ are about 9%. And IHC 3+, we haven't observed for this particular group. Those that are 0 or 1+ should be considered HER2 negative. Those that are 2+, a FISH assay can be repeated, and when the assay remains unchanged, they can be scored as negative with a comment. I would recommend, if you see 3+ staining in cases that have this FISH outcome, you should consider that they might be false positive results and refer them for a second opinion. Group 3 is on the next slide. And similarly for this group, with a ratio less than 2 and average HER2 copy number greater than 6, the majority of cases are 0 or 1+, about 3/4 of them in our studies. The IHC 2+ and 3+ represent are about equally divided for the remainder. Those, and in our hands, we consider this particular group to be a mixed group of breast cancers containing at least 2 different groups, one that's amplified and one that's not amplified. Although the ASCO-CAP guidelines recommend that if the immunohistochemistry result is 0 or 1+, these should be evaluated as negative with a comment. If they are IHC 3+, they should be evaluated as HER2 positive with a comment. And in between, if the immunohistochemistry in the same lab is 2+, they should be further screened in a blinded fashion by FISH. If the results are positive, the ASCO-CAP guidelines recommend considering them HER2 positive. In our lab, we actually subject them to additional procedures using alternative probes, which I briefly summarize on the subsequent slides. When we unblinded our data and looked at cases that were screened for entry to Cancer International Research Group clinical trials, these group 3 cases, as I've indicated, actually were categorized into those that had been reported as amplified and those that had been previously reported as not amplified. We refer to these as group 3A and group 3N to designate amplified or not amplified. The average HER2 copy number of the amplified cases was much higher. It was about 16 per tumor cell, whereas those that were not amplified was only about 7. Likewise, with the immunohistochemistry for the amplified cases, the immunohistochemistry was predominantly 2+ or 3+, whereas for those that had been previously characterized as not amplified, they had predominantly 0 or 1+ immunohistochemistry. And on the next slide is an example of one such case. And you'll notice that the average HER2 copy number is relatively high, 23. The signals are grouped together with the green chromosome 17 centromere signals. And this high copy number with grouped signals is for us very characteristic of cases that have HER2 gene amplification that typically have 3+ or 2+ immunohistochemical staining. And on the next slide shows the way in which cases that are characterized by FISH as being in group 4, and a ratio less than 2 with an average HER2 copy number between 4 and 6, when the immunohistochemical staining that is recommended to be done is performed in our laboratory, the vast majority of these are either 0 or 1+. We report them as negative. A small number of them have immunohistochemistry 2+. We do some additional characterization of them, and these cases typically are reported out as negative with a comment. Again, for this group, if you find that your laboratory says they're 3+ positive, I recommend a high level of skepticism and recommending them out for a second opinion as possibly false positive by immunohistochemistry when there's this conflict between FISH and immunohistochemistry. On the next slide shows the reason that alternative probe use can be problematic. This is a study that we published a year ago with Christina Curtis's group at Stanford, and it demonstrates simply across the top for nearly 2,000 breast cancers that had either slight levels of HER2 loss, HER2 normal, in other words, not amplified, HER2 gain, which represents 4 to 6, or HER2 amplified. If we then looked at the alternative probe sites, the genomic site that's used on chromosome 17, you'll notice LIS1, those that have a loss, and if we go over in the red box that have HER2 gain, more than half of them have heterozygous deletion of this site. Likewise for P53, more than half have heterozygous deletion. The D17S122, which is quite popular at some referral labs, you'll notice is also more than 50% heterozygously deleted. Likewise for RA1. And the probe sites that we've investigated that are on the Q arm of chromosome 17 for some reason are more stable and less frequently heterozygously deleted. So one needs to know when using these to be able to evaluate whether these sites are heterozygously deleted. That can be done by FISH, and we've described an approach that allows it to be done in that paper. The subsequent slide moves on and summarizes the overall approach that we use with these, showing the groups from 1 to 5 on the left, the ratios by FISH, the average HER2 copy number by FISH for each of these 5 groups, the original FDA designations as amplified versus not amplified, the way they are currently viewed either in 2014 or 2018 by the ASCO-CAP guidelines as ISH positive initially for the top 3 groups, but now the second and third group are recommended for additional evaluation by immunohistochemistry. The fourth group has been considered equivocal, and recommended for immunohistochemistry, whereas the fifth group by ASCO-CAP guidelines is considered HER2 not amplified. And our evaluation of these is summarized on the right-hand extreme in terms of our collaborative data with the Breast Cancer International Research Group, our now known as TRIO, Translational Research in Oncology. We consider the first one amplified with overexpression, the last one not amplified with low expression, the fourth group not amplified with low expression, the second group not amplified with low expression. Group 3 is a mixed group containing both amplified with overexpression and non-amplified cases that lack overexpression. So thank you.
Thank you so much, Mike. That was an amazing amount of densely packed but critically important information to help clinicians sort through HER2 FISH testing. I think my take home is, first of all, this last table you've put together, I'm printing and I'm going to use in the clinic to help me sort through pathology reports. And then I'm just going to say it. Why aren't we all doing FISH? Why aren't we getting rid of IHC and only using IHC if we have to sort out one of these indeterminates? Is there any move in the guidelines to go to an all FISH assay, or is there any downside?
We've advocated that for a long time in collaboration with Dennis Slayman's group. When we were screening for entry to BCRG clinical trials in 2000, we needed to choose an assay. We chose FISH, not immunohistochemistry. In our laboratory, we routinely do both. When we have a request for FISH only, we run our laboratory developed assay in the background because I like to know the result of both assays. It also allows me to address immunohistochemistry assays that are performed in outside labs that may or may not differ from what we're finding in our laboratory. So we run them both. FISH is by far in our laboratory the preferred assay.
Thank you so much. And now in the interest of time, we're going to move on to our next section, which relates to the management of treatment-resistant HER2 positive breast cancer. And what we're going to do is get the audience involved here. You should see an audience response question on your screen. You can vote now, and I'll read out the question. The question is, which of the following would provide a high disease control rate for patients with HER2 positive metastatic breast cancer following 2 lines of therapy without brain metastases? Your options are Margitatuximab plus chemo, trastuzumab deruxtecan, tucatinib, trastuzumab, capecitabine, or neratinib, capecitabine. Go ahead and vote now, please. All right, a very nice smattering. Shanu, you've got a lot of work to do here. I certainly think that at least 2, 3, and 4 are certainly available to our patients right now, but I think Shanu's gonna take us through some data that will help highlight, maybe give us some direction in what we should be doing in the setting of 3rd line metastatic HER2 positive breast cancer. In the interest of time, I'm going to go to the next question here. This is a patient case. Your patient is a 52-year-old woman with de novo metastatic, ER positive, PR negative, HER2 3+ breast cancer involving the left breast, liver, and bone. She's had first-line THP times 6 cycles, had a partial response, HP followed by anastrozole in the maintenance setting, and then 28 months later, she has progressive disease in her lungs. Now, this is a 2nd-line setting. Now, what treatment would you recommend? Either neratinib, capecitabine, trastuzumab emtansine, fulvestrant trastuzumab, tucatinib, capecitabine, trastuzumab, or trastuzumab deruxtecan. So this is 2nd-line HER2 positive metastatic disease. Please vote. Okay, we are seeing here that the winner is actually tucatinib, capecitabine, trastuzumab. So we have a lot of enthusiasm with the recent data relating to tucatinib that Shanu will be going through. Trastuzumab emtansine is actually the sort of data-driven, guideline-backed recommendation in the 2nd-line setting right now. So we don't have yet a study that shows tucatinib, capecitabine, trastuzumab is better than trastuzumab emtansine. But Shanu will talk to you about the FDA approval of tucatinib and how the FDA is actually allowing us to use it in the second line in spite of not having data. All right, last question before we get to Shanu's data. The COVID pandemic has certainly impacted us and all of our patients. So I'm going to ask you a very clinically relevant question right now. So this is a 62-year-old woman, ER/PR negative, HER2 positive metastatic breast cancer, first line THP, second line TDM1. She's had eribulin trastuzumab and lapatinib capecitabine. So we're now going on to fifth line therapy. She has disease in her liver and lungs, and she starts this very exciting new ADC, trastuzumab deruxtecan. She has a very brisk response. 4 months later, she has a worsening cough, however, and a low-grade fever. Pulse ox shows 93% on room air resting. Now, her chest CT shows resolution of one of the lung masses, stabilization of the other smaller nodules, but new ground glass opacities in the upper lobes, bilateral lungs. What should you do next? Do you hold trastuzumab deruxtecan, test for COVID-19, and if negative, refer to pulmonology for workup? Do you continue trastuzumab deruxtecan, initiate steroids, and refer to pulmonology for workup? Do you hold trastuzumab deruxtecan, test for COVID-19, and if negative, resume trastuzumab deruxtecan and start steroids? Or do you hold trastuzumab deruxtecan, test for COVID-19, and if positive, resume trastuzumab deruxtecan? Or do you DC therapy due to progression and initiate the next line of therapy? Complicated case, but very clinically relevant. Go ahead and vote. Okay. Very good. So the audience chose number 3, which is to hold it, test for COVID, and if negative, resume trastuzumab deruxtecan. But actually, the answer is to hold treatment, test for COVID-19. If it's negative, actually, we should get pulmonology involved because this would be consistent with interstitial lung disease or pneumonitis. So we wouldn't want to just resume trastuzumab deruxtecan. We would want to refer to pulmonology, possibly bronchoscopy, possibly steroids. We're going to talk a little bit about this further. And so now this was just sort of to pique your interest. Shanu is going to go through some very exciting data. This is a picture here of all the therapies we now have available to us according to NCCN guidelines and approvals. Very exciting at 3 new approvals just in the last year. Shanu, help us know how and when to use each of these agents.
Great. Thanks, Sarah. So, I think what we see up here is really up until very recently, shown in the green boxes has been our sort of approved guidelines or standard of care treatment for HER2 positive advanced stage breast cancer. And we've preferred to start off in the first line setting with a combination of a taxane plus trastuzumab and pertuzumab. This is really based on the unprecedented survival data from the Cleopatra study. Our sort of time-honored second-line option has been TDM1, and actually that's based on the Amelia data, where we saw, again, a survival advantage for TDM1 compared to other standard of care therapy. In the third line and beyond, of course, there are a number of available therapies, and most of these have not been directly compared to each other, and most have a fairly modest level of activity. And so there's really no one preferred treatment in that space, and it's really been up to physicians and their patients to choose in that setting. But as you all know, over basically a 6-month span of time this past year, we saw the rapid approval of 3 new HER2 targeted therapies. And so if we look based on their approval where we would slot these new agents, in the second line setting, we did see an approval for a favored regimen by our audience, which is the tucatinib, trastuzumab, and capecitabine. And this is really based on the data from the HER2 CLIMB study. And then in the third line, we've seen 2 new additions, the first being trastuzumab deruxtecan. It's previously called DS8201A, and we abbreviate it as TDXD. And this was based on really compelling data from the Destiny Breast 01 study. And then finally, the doublet combination of neratinib plus capecitabine based on the randomized NALA trial. Next slide. And so, I mean, there are a number of very exciting, recently approved drugs and other drugs in test stages of testing on the horizon for HER2 targeted therapy. And so I'm just going to take you through the pivotal studies that have led to these new drug approvals and what's sort of waiting in the wings based on recent data from large studies. Next slide. So to jump right in then, I mean, starting with the antibody conjugates. So antibody conjugates are actually really interesting drugs. They combine antigen specificity with potent cytotoxicity in a single molecule. And so in general, they're comprised of a monoclonal antibody, an antigen-specific monoclonal antibody, and attached to this via special linkers is a cytotoxic payload, often a chemotherapy agent. And we're very familiar with ADCs because we've been using TDM1, which is the prototype ADC in breast cancer for many years now, early on in the metastatic setting and more recently in early stage patients as well. But ADC technology has really evolved over the last few years, and there's new linker technologies, there's novel potent payloads. And so today there are over 60 ADCs in clinical testing for various types of illnesses, including cancer. And just on the right here to remind you how these drugs work. So once the antibody finds its target antigen, the whole complex is internalized. And then within the cell, the linkers are cleaved, releasing the chemo to eradicate the cancer cell. Some payloads are actually cell membrane permeable, and they have the ability to pass through and then interact with neighboring cells, kill neighboring cells, some which may not even have the target antigen. And this is what we call the bystander effect. So trastuzumab deruxtecan is a new or novel HER2 antibody drug conjugate, as we've heard about. And if we compare and contrast it briefly to TDM1, so both of these drugs essentially have trastuzumab as the monoclonal antibody backbone. But the payload in TDXD is a topoisomerase 1 inhibitor. It's a very potent chemo agent, and it's very novel. I mean, most breast cancer patients are not exposed to chemotherapy of this class, so it's very new for our breast cancer patients. There are also twice as many chemo molecules linked to each TDXD monoclonal antibody compared to TDM1. So we deliver a lot more chemotherapy with each one of these antibody drug conjugate molecules. And in fact, the chemotherapy in TDXD is membrane permeable, so it has this potential to induce a bystander effect. So the pivotal study really for trastuzumab deruxtecan is the DESTINY-Breast01 trial. And this was a phase 2 study and was conducted in patients who had centrally confirmed HER2 positive metastatic breast cancer. And all of these patients had to have had prior TDM1 to be eligible. And so the study was conducted in two parts. The first part was a dose finding phase. And so once they defined 5.4 milligrams per kilogram, which is given every 3 weeks by intravenous infusion, as the best phase 2 dose, all patients in part 2 were then treated with that dose of TDXD. And overall, there were 184 patients eligible for this analysis. The primary endpoint of this study was to look at the overall response rate, and this was confirmed by an independent radiology review. And as you can see here, I mean, this study enrolled a pretty heavily pretreated group of patients. I mean, the median number of lines of prior therapy for metastatic disease was 6. All patients had prior trastuzumab and TDM1, and 2/3 also had prior pertuzumab, so a very heavily pretreated cohort of patients. This is a waterfall plot that I'm sure many of you have seen. Is this efficacy data, and I mean, I think it's pretty spectacular and I think striking, and it kind of I think visually shows you just how active this drug is. I mean, the confirmed overall response rate was 61% in these pretreated patients. And even if patients didn't achieve a confirmed response, you can see here that all patients had at least some benefit from this therapy. So the disease control rate is exceptionally high. It's 97%. In fact, 6% of patients achieved a complete remission with this therapy, and that's very unheard of in such a late line setting. So very, very impressive efficacy data with this drug. And I think as important as the response rate is the durability of this benefit. And so on the left is a progression-free survival curve, and you can see the median PFS for this group of patients was 16 months. And just to put that in perspective, in sort of a late line setting with other currently available therapies, the median PFS we are seeing with our best drugs is 6 months. So this is pretty striking to see a PFS like this in a late line setting. The overall survival was not achieved at the time of reporting and publication of this data. And I think we may be seeing some OS data later this year, perhaps at San Antonio. The median duration of benefit also, I think, equally impressive, 15 months. So patients stayed on this therapy for over a year. And again, think of the last time you had a patient on 6th-line therapy who lasted on their next treatment that long or had disease control that long. There was a small group of patients that enrolled on this study who had brain metastases at baseline. And these were patients who had treated and stable brain metastases. This is a type of patient that is enrolled, I think, fairly regularly on our systemic therapy trials. And this was a small group of 24 patients in this study, but the median PFS for that group of patients was 18.1 months. So they did as well, if not slightly better than the overall patient population in the trial. And so, while this doesn't really tell us that there is activity for TDXD in the brain, but there is a hint there that these patients with brain mets did as well as patients without brain mets. And so I think there is, I think, as I was saying, enough of a hint that there may be some benefit with this drug in the CNS, and there are studies ongoing now to actively investigate that. So it's pretty exciting.
These data are so compelling, Shanu. I don't ever remember seeing a waterfall plot that looked so dramatic in such heavily pretreated patients.
Right.
But now we're in the COVID era, like our case highlighted, and we have patients who may develop shortness of breath or cough, and we have this AE that occurs with this drug. Can you tell us a little bit more about the toxicity profile with this drug?
Right. I mean, I think that's really important. So, on a data, the most frequent toxicities we saw with, or we see with TDXD are really of a GI nature or bone marrow suppression. And that's sort of typical for a topo-1 isomerase inhibitor payload. And so on the left here, you can see that, in fact, the most common toxicity was nausea. But with these patients weren't pre-medicated. But I think when you give patients pre-medication, anti-nausea medication, you do see that this is a very manageable level of nausea that we see with this therapy. And overall, you can see by the orange bars that most of the side effects were grade 1 and grade 2 in nature, so very manageable. There was, as Sarah alluded to, one toxicity that was really important to highlight, and that's lung toxicity. And it ranges all the way from very asymptomatic findings on CAT scans all the way up to, and we saw a few cases of this, of fatal lung toxicity as ILD or interstitial lung disease on patients in this trial. Overall, about 14% of patients will have some level of lung toxicity from TDXD. So, and you'll see here the median onset of that lung toxicity is 4 to 5 months. So, you need to be vigilant over these patients for their whole duration on this therapy. And so what that means is both patients and physicians have to be aware of new or worsening pulmonary symptoms and new findings on imaging. And it's really important to act early. And by that, I mean holding the therapy until you rule out or exclude interstitial lung disease or pneumonitis. And in many cases, the recommendation is to start steroids early. So I think with awareness and prompt intervention, and in some cases you have to discontinue the therapy, we can prevent some of the more serious potential consequences of this lung toxicity. So Following up on the Destiny-1 study, these are the two follow-up confirmatory phase 3 trials, and both are well underway now. The first study is Destiny-Breast02, and it's the follow-up study. It's for post-TDM1 patients, again, comparing now TDXD to patients who get investigator's choice of treatment. So it's a randomized study. And Destiny-Breast03 is a study, again, for HER2-positive metastatic breast cancer patients, and this time comparing TDXD directly to TDM1, so patients are being randomized. So really exciting follow-up phase 3 trials for Destiny-Breast01. One of the other things we know, and it's related to the, I think, the superior pharmaceutical properties of TDXD, the fact that it has this bystander effect and a very potent payload, is we've seen activity in HER2 low breast cancer. And by that, I mean HER2 1+ and HER2 2+ FISH negative breast cancer is what we traditionally call HER2 negative breast cancer, and for which our currently available HER2 targeted therapies are inactive, like trastuzumab. But we did see evidence of activity for this group of patients with TDXD, both preclinically, and shown here is a waterfall plot from a phase 1 trial of trastuzumab deruxtecan in patients whose tumors had low HER2 expression. Again, this was a group of patients who had 6 or 7 prior lines of treatment. And again, you see a better than expected response rate in the range of about 37%. So very exciting. And these phase 1 data, in fact, have led to the ongoing randomized phase 3 trial, which is called Destiny-Breast04. Again, this is now a randomized study for patients with HER2 low 1+, 2+ breast cancer, and they're being randomized to TDXD or physician's choice of chemotherapy. Finally, I want to mention another exciting HER2 ADC that is just on the horizon. This one is called trastuzumab duocarmazine, very much an ADC with trastuzumab backbone, but the payload here is an alkylating agent. Duocarmazine is a DNA damaging agent. This drug also has a potential for a bystander effect. And so on the top here is a waterfall plot from the phase 1 study of this new HER2 ADC. And you can see for HER2 positive patients, again, in a pre-treated group of patients, a response rate of 30%. The bottom 2 waterfall plots are for patients who have HER2 low breast cancer. So again, with this bystander effect, this drug is active even for this group, which we traditionally call HER2 negative. On the left is the group of patients who are ER positive, HER2 low, and on the right is the group that is ER negative, HER2 low, also called triple negative. And we're seeing, I think, pretty dramatic activity in that setting. These data already led to a phase 3 trial called the TULIP trial, I think, which is now, which is a randomized phase 3 trial of this ADC versus standard of care. It's fully enrolled, and we're now awaiting results from that trial.
Those data are great regarding the ADC world. I think we're going to hopefully see even more ADCs come to light, and I'm really excited about the phase 3 data associated with DS8201. But there are also a couple of tyrosine kinase inhibitors that have been recently approved as well. Can you take us through the data of these newer orally bioavailable molecules?
Right, yeah. So, I mean, tyrosine kinase inhibitors, as you know, block the intracellular tyrosine kinase domain of these receptor tyrosine kinases. And so basically, in this way, they're able to block the downstream signaling cascades. And as you mentioned, they're also of importance because they're small molecules. They have the potential to pass through the blood-brain barrier and be active against CNS disease. So as you can see here, there are a number of already approved and other TKIs in development. Lapatinib, of course, was the first of these, and it's a HER1, HER2 reversible tyrosine kinase inhibitor, and it's used in combination with capecitabine, usually in late-line setting, and has overall modest activity. Neratinib, by contrast, is an irreversible pan-HER family kinase inhibitor. So it has the potential for a much more potent HER2 blockade. And it was first actually approved in the early stage setting for HER2 positive breast cancer, and only recently has received a label for the metastatic disease. And this is based on the results of the NALA trial as shown here. Next slide. So the NALA trial, this is a phase 3 randomized study for patients with pretreated HER2 positive breast cancer. Patients had to have at least 2 lines of therapy, and then were randomized to either standard of care lapatinib plus capecitabine or neratinib plus capecitabine. And there are 2 co-primary endpoints for this study, PFS and OS. Next slide. And shown here are those 2 curves on the left. You can see that, in fact, in the NALA trial, there was a statistically significant improvement in PFS with an absolute gain of 2.2 months in favor of the neratinib arm. Unfortunately, although there was a numerical improvement in overall survival, this was not a statistically significant improvement. But based on the PFS data, this is a positive study. There were also other secondary endpoints that favored neratinib. The overall response rate and the duration of response also were improved in the neratinib arm. I think one of the really interesting secondary endpoint analysis was the time to intervention for CNS metastasis, which favored the neratinib arm. Overall, there were less patients requiring CNS radiation in the neratinib arm, and a lower overall cumulative incidence of brain metastases also in the neratinib arm compared to lapatinib, which is consistent with what we know about this tyrosine kinase and its effect in the CNS space. In terms of toxicity, I mean, I think it's well known to most of us treating breast cancer patients that the main dose-limiting toxicity of neratinib is diarrhea. And in this trial, with very aggressive mandated diarrhea prophylaxis, they still saw a grade 3 rate of 24%, which was double that of the lapatinib group. In spite of that, there were less patients who discontinue treatment on the neratinib arm for toxicities compared to the lapatinib arm. So a lot of work has gone into trying to find ways to mitigate the grade 3 diarrhea rates. And in the control trial, several maneuvers were looked at, including aggressive loperamide use, adding budesonide steroid to loperamide, using a bile salt binder with loperamide. And they're all effective, but I think what was most effective is, if you look in the first box to your left, was a dose escalation strategy. And with that approach, we saw the lowest rates of grade 3 diarrhea at 15%. And in that approach, you start by using the half dose and gradually building up to full dose, allowing patients an opportunity to get used to the new therapy. And it seems to work best in mitigating the diarrhea. So a more successful way of delivering this therapy. So tucatinib, to differentiate it, it is a selective HER2 kinase inhibitor. So by specifically not inhibiting HER1, we see less GI and skin toxicity with tucatinib. And in fact, that's what we saw in the very first phase 1 study shown on the right here, with the combination of tucatinib added to standard capecitabine and trastuzumab. There were no grade 3, 4 rates of no cases of diarrhea, only grade 1 and grade 2, and very promising activity. And this phase 1 then led to the HER2 CLIMB study that we made reference to earlier. And so this is a randomized phase 2 trial. Again, this is for patients who had a lot of prior therapy with HER2 targeted agents, some of our best drugs, trastuzumab, pertuzumab, and TDM1. These patients were randomized then to either a standard combination of trastuzumab plus capecitabine, or trastuzumab, capecitabine, and tucatinib. Tucatinib is given as an oral therapy twice a day. One of the most unique, I think, features of this trial is that this study enrolled patients with brain metastases. And if you go to the next slide, you'll see that almost 50% of patients on the study had brain metastases, and they were balanced equally in both arms of the trial. What's interesting is, of this group of patients with brain mets, 60% had treated stable brain mets. So that's a typical group of patients in most of our systemic study trials. But what was atypical is that 40% of that group had active brain metastases, either untreated or treated and progressing brain lesions. So that's a group that's usually excluded from our systemic therapy study. So this was a really novel design for the HER2 CLIMB study. And so these are, on the left is the primary endpoint curves of the trial, the PFS curves, and you can see there was a statistically significant, almost a 50% reduction in the risk of progression or death with the addition of tucatinib triplet therapy here. The absolute gain was 2.2 months. On the right is the overall survival curve. It was a secondary endpoint, but you can see here there was again a statistically significant and impressive improvement in OS with an absolute survival gain of 4.5 months for the tucatinib patients. So very compelling, I think, efficacy data. These are some other secondary endpoints on the left. You can see that there was a doubling of the response rate, went from 20% to 40% for patients with tucatinib therapy. And on the right, they all, again, looking just at the group of patients who had brain metastases. Remember, this is about half the patients on the trial. These are the median progression-free survival curves for the brain mets patient. And again, even for this group, you saw that there was a significant improvement in PFS for the patients who were randomized to tucatinib with an, again, 2.2 month improvement in PFS. I think another striking sort of finding in this graph is looking at the 1 year landmark point. You can see that there are about 25% of patients in the tucatinib arm that have not had any progression at the 1 year point, but all the patients in the control arm have had progression of their disease. So again, I think more compelling efficacy data for this tucatinib therapy. Overall, it is a well-tolerated triplet regimen. The most common toxicity was diarrhea, even though this is a selective inhibitor, but the rates of that diarrhea are predominantly grade 1 and grade 2. So, only 13% of patients had grade 3 diarrhea in this trial, but that was, again, without aggressive prophylaxis. There was some grade 3 LFT elevations, which was reversible, and more patients on the tucatinib arm had hand-foot syndrome, but also these patients stayed on trial much longer than the patients on the lapatinib therapy, which may explain that particular finding. Overall, there were few patients who discontinued therapy for toxicities. And so the HER2 CLIMB study has now led to a confirmatory phase 3 trial, the HER2 CLIMB 02 trial. And in this study, patients who've had prior trastuzumab and taxane therapy in the metastatic setting are randomized to either standard of care TDM1 or TDM1 plus tucatinib. And this study is also well underway.
It's really exciting and compelling data. And I think, when we do our Q&A, we're going to probably have to get into the nuts and bolts of how to choose among all of these therapies we now have at our disposal. But before we complete this section, there is a therapy that may be FDA approved shortly. Can you talk to us a little bit about Margitatuximab?
Yeah, I mean, so Margitatuximab is also in late stages of development. As you said, it's with the FDA currently. So this is a novel HER2 monoclonal antibody. So it's much like Herceptin, except the FC, or trastuzumab, I should say, the FC domain, however, has been modified. And specifically, it's been engineered to have enhanced binding to receptors on immune cells. So specifically, Margitatuximab has an increased binding for the activating CD16A receptors on immune cells and less binding for the inhibitory CD32B receptors on immune cells. So it has the potential to induce a much more vigorous immune response against cancers. We see that approximately 85% of the population actually has the genotype for a low binding CD16A receptor. And that's by virtue of having an F allele, either heterozygous or homozygous, as shown in the bottom right corner there. And so this is a group of patients that would be predicted to have a much more pronounced benefit from Margitatuximab as opposed to trastuzumab. And so the SOPHIA trial is the pivotal phase 3 study for Margitatuximab. And in this study, again, patients with prior treatment, at least 2 lines of treatment for HER2 positive metastatic breast cancer, were randomized to standard of care chemo plus trastuzumab or chemo plus Margitatuximab. And there are two co-primary endpoints, sequential endpoints, I should say, PFS and OS, and a really interesting exploratory endpoint looking at the CD16 receptor genotypes that patients had in relation to the efficacy of Margitatuximab. Next slide. And so these are the primary endpoint curves. On the left, you can see that there was a statistically significant improvement in PFS going from 4.9 to 5.8 months in favor of the Margitatuximab arm, which is about a 25 or 24% reduction in the risk of progression with the Margitatuximab therapy. The absolute gain is modest, however, at only 0.9 months. On the right is an interim, it's a second interim OS analysis. Again, we're not seeing a statistically significant improvement at this point, but we do expect more mature data for this OS endpoint later this year. Finally, I think what was most exciting was the exploratory analysis, where they looked at response based on patients who had that F allele, the homozygous or heterozygous F allele carriers. Remember, that's a bulk of patients on the trial. It's 86% of the patients on the trial. And you can see this group, in fact, does have a more robust response to Margitatuximab compared to trastuzumab, where there's almost a 2-month improvement in median PFS and a 4-month improvement in overall survival. So certainly these are exploratory findings, but they're certainly, I think, interesting and suggest that perhaps we need to look at a genotype, the genotype selection as a way to determine which patients may best benefit from this therapy in the future.
Thank you so much for that amazing summary. Again, very dense amount of information, a ton to go over. We're going to go on to another question. I think we're going to have a lot of good questions at the end. So I'm going to round up the end of this program to give us some time for some Q&A. So with which of the following does the HER2 receptor dimerize to promote proliferation and survival via the PI3 kinase AKT signaling pathway? Is it A, epidermal growth factor receptor, B, HER2, C, HER3, or D, HER4? So please go ahead and vote. Okay, so we've got HER3 as 23%, which is actually correct. And we're going to go into a little bit of data to highlight this. Now, HER2 gets activated by dimerizing with other partners, but the preferred partner and the strongest activator of the PI3 kinase signaling pathway is HER3. So we're going to now talk a little bit about HER3 in breast cancer. And before we do that, I worked with CME Outfitters to create what I think is a very useful animation that characterizes the unique biology of HER3-initiated signaling in cancer, including activation of downstream signaling pathways. So let's look at a clip of that animation right now. It's only about a minute or so.
Shown here is a cross-section of the cell with HER2 and HER3 tyrosine kinase receptors visualized. HER2 does not have any known ligand. However, HER3 does have a ligand, and when that ligand engages with the extracellular domain of HER3, this induces a conformational change in HER3 that exposes the heterodimerization site. This allows HER3 and HER2 to heterodimerize. The activated HER2 then phosphorylates the intracellular C-terminal tail of HER3. The phosphorylated tyrosine residues on HER3 act as docking sites that interact with and recruit downstream signaling proteins, PI3 kinase and AKT. HER2 and HER3 are a potent heterodimerization pair due to the multiple PI3 kinase docking sites located on HER3. Clinically, this pairing has relevance because a monoclonal antibody, pertuzumab, has been designed that blocks HER2 at the HER2-HER3 dimerization site.
So I think that gives us a highlight of how HER2 and HER3 engage to activate the PI3 kinase pathway. This segment and the full animation will be available on the CME Outfitters website, and we hope you'll use it in teaching your peers or patients. Now let's talk a little bit about HER3 somatic mutations and overexpression. We know that a minority of cancers have HER3 mutations, somatic mutations, which can be activating. You can see here, breast cancer is around 1%, but you can go up to about 6% in some other cancers like GI cancers and GU cancers. But it's important to also recognize that overexpression has been reported in a number of cases, with overexpression being estimated to occur in breast cancer on the order of 15 to 40%, depending on the antibody used. And patients who have HER3 overexpression tend to have a worse outcome. On the next slide, there is a lot of data that actually supports that HER3 may be implicated in the pathogenesis of HER2 positive breast cancers using transgenic mouse models that develop HER2 positive breast cancer. When the HER3 is repressed, it actually leads to diminished tumor cell growth and proliferation. And if you do knockout models using CRISPR technology, you see the same thing. You can diminish the growth of HER2 positive breast cancer. So this may be a strategy to go for in HER2 positive breast cancer. In contrast, EGFR, which is HER1, and HER4 don't seem to supplant the requirement for HER3 as the requisite partner for HER2 in these types of experiments. Next slide. So we know that co-expression of HER2 and HER3 is linked to tamoxifen resistance. ER-positive breast cancer cells, when treated with fulvestrant, can induce protein expression and activity of HER3. And targeted therapy of HER2 has been linked to trastuzumab resistance when there is HER3 expression or upregulation, as well as lapatinib resistance. So a growing understanding of HER3 as the principal partner for HER2 in its oncogenic activities, and accumulating evidence implicating HER3 activation as a cause of treatment failure is driving the development of numerous HER3 targeted agents. And on this next slide, you can see a table that is summarizing select HER3 targeted agents in clinical development. The furthest along is the U3-1402 antibody, which I'll talk about in the next slide a little bit further. What you can see is this is an antibody drug conjugate comprised of patritumab, which is a HER3 targeted antibody stably linked to a topoisomerase inhibitor made by the same company as trastuzumab deruxtecan. It's got a similar idea behind it. Next slide. So this has been evaluated in phase 1 and 2 clinical trial in heavily pretreated patients, and it's shown promising anti-tumor activity with a confirmed objective response rate of 43% and a median PFS of 8 months. And interestingly, the efficacy does seem to be seen regardless of the metastatic breast cancer subtype. So half of them were hormone receptor positive, about a quarter were triple negative, and 17% were HER2 positive. So I'm actually excited to see more data relating to this exciting molecule and the treatment for all different types of breast cancer with HER3 overexpression. Next slide. Now, in the last few minutes, I'd like to shift gears and move on to COVID-19 and breast cancer. I'm just going to spend 2 minutes on this because I do want to get to a robust Q&A in our last 10 minutes. And I want to just highlight some ways that we might consider to provide high quality care to our patients during this pandemic. Next slide. So there have been a number of guidelines which are really expert recommendations because we don't have enough evidence with the pandemic to actually support level 1 evidence guidelines, but a number of recommendations have been published or promoted relating to how we should prioritize patients for treatment of breast cancer or of cancer itself. And the highest priority are certainly in patients who have unstable clinical scenarios, active metastatic breast cancer, or a new diagnosis of invasive breast cancer. Certainly breast cancer during pregnancy is important to prioritize, and patients who are on therapy and having important side effects should be seen. But the lower priority patients, we really try to push toward telemedicine or video visits to minimize the foot traffic through our clinics, protecting our clinicians and protecting other patients who do need to come into the clinic and are immune suppressed. And my bottom line here is, use common sense as much as possible in determining how to prioritize. Next slide shows the 30-day all-cause mortality in patients with COVID-19 and cancer, indicating that those patients who have cancer are at a higher risk of mortality, and a variety of other factors have been identified as being linked to mortality, including active cancer, whether it be stable or progressing on treatment. A poorer performance status 2 or above has been associated with worse outcome as well, and of course patients who have other comorbidities, 2 or more comorbidities, have a worse outcome. So these all make a lot of sense. Now, there are some considerations you might make for patients who are older with breast cancer during COVID-19. Certainly for HER2 positive breast cancer, maybe don't be as aggressive in the neoadjuvant setting with cytotoxic chemotherapy. Consider using hormonal approaches or hormonal with HER2 targeted therapies. Just be mindful of the immune suppressive therapy we're using. However, we don't have outcomes data to support a full de-escalation approach. So I think if we're really careful with our patients, and we have a high functioning 75-year-old with an aggressive tumor, we need to treat as standard of care aggressively. In terms of metastatic disease, it's important always to talk to patients about goals of care and palliative therapy, and consider postponing things that are going to lead to sufficient immune suppression. I have a lot of patients on CDK4/6 inhibitors and a lot of patients on HER2 targeted therapies who are during the COVID era, and I don't feel compelled to stop therapy just because of COVID, but I am educating my patients very closely and watching them closely, as well as their scans during this time. The next slide. So SMART goals it's an acronym to help us remember to incorporate and practice specific, measurable, attainable, relevant, timely goals, optimize HER2 testing, identify HER2 positive breast cancer, and know that we are now in an era where we're testing newer therapies that might target patients who have HER2 low disease or HER3 positive disease. This is a very exciting area. Sequencing of patients' treatment after the third line or third line and beyond is something that is evolving because we have a number of drugs available and no trials to tell us how to properly sequence them. And it's important to tailor cancer treatment during the COVID era. So now let's turn to our Q&A. We just have about 5 minutes here to do some questions as well as discussion. And so making sure my colleagues, Shanu and Mike, have their microphones on. One of our patients asked, Shanu, a community oncology is asking, how do you manage diarrhea? And I would add nausea with TDXD. What are you doing clinically? Because I am seeing this as well in my own practice.
Right. So I rushed through this, but I think the most common sort of day-to-day toxicity that we saw for patients on TDXD was nausea. And early in the trial, I mean, we didn't pre-medicate for this. And in the label, in fact, now that it's approved, that again, there were no recommendations. But I think given the experience and the rates of even grade 1 and 2 nausea that we saw on the trial, we at our own institution have made a decision to use prophylactic antiemetics. And so all patients will get a long-acting 5-HT3 agonist. Palinositron is what we use, and we give them a small dose of steroids for the delayed nausea as well. And then, so that's the pre-medication, and it's standard. I think you can always scale back for patients who are doing well and don't need it. And there are a number of patients who don't. For post-treatment, I mean, we give everyone a prescription for, again, something like Zofran or ondansetron, or Compazine to have in case they need something more. So in many ways, it's how we would treat our patients who were on a highly emetogenic chemotherapy regimen, basically. In terms of the diarrhea, I mean, it's quite funny because this is a topo-1 inhibitor payload, and diarrhea is what we would expect, but we actually saw probably a balanced amount of diarrhea and constipation with this therapy. And so I think, again, as we manage diarrhea from something like irinotecan, for example, the goal here is to use anti-motility agents. So loperamide is what we would go to first.
Excellent. Thank you so much. Very useful, and certainly seeing more of that than ILD in practice, so it's important to address. Right. Mike, we got a question for you. How often does the biology of a tumor change, i.e. truly being HER2 negative at the primary diagnosis and then positive at the time of metastases, or vice versa? Do you have any data on that, or do you have a sense just from all of the opinions you give for people around the country?
We haven't formally analyzed our data, but it's pretty unusual. What is pretty common, if you look at most of the studies that indicate that it changes relatively frequently, let's say 20% of the time, I think a lot of those are in the past, they've been predominantly immunohistochemical assay studies that have not used FISH. In our lab, we see it relatively infrequent. Although we have seen it, it's not common. I would expect it in the 1% to 2% range. We're talking single-digit percentages. It's not frequent. We have seen it where the original sample has what we would call HER2 heterogeneity in the biopsy. That happens about 1% of the time in the breast cancers we see. And the metastases wind up being either, depending on, I suspect, depending on how they've been treated.
Excellent. Thank you. And I think we just have time for one last question. A couple of people asked us to go through the initial questions again and give our answer about how we treat these patients. So the first one we'll take is a patient's second-line treatment. She's had first-line THP, second-line therapy. What would you recommend, Shanu?
So I tended to disagree with the audience. I mean, I don't think anyone can be dogmatic, and I selected TDM1. As I said, up until recently, TDM1 really was our preferred second-line therapy based on great data from the Amelia trial, but based on again very compelling results as we reviewed from the HER2 CLIMB study, we now have a label for tucatinib in the second-line setting as well. So frankly, both options are reasonable. But from my perspective, what I think is important to point out is that all the patients in the HER2 CLIMB study had previously received TDM1, and so in that space, those patients were still able to have a really dramatic survival benefit with subsequent use of tucatinib. We don't actually know about that reverse scenario. If we used tucatinib first, would we still get that great mileage out of TDM1? And so I think being a purist and sort of inferring from the data as best as possible today, I would still lean towards using TDM1 as my preferred second-line option in that setting.
Sounds good. So the other two, one was addressing third line and beyond, and we do, as Shanu nicely presented, have 3 new approvals: tucatinib, trastuzumab, capecitabine. Great data, and data supporting trastuzumab deruxtecan, also great data, single-arm phase 2 trial. So we don't have randomized data, but both are approved there. And then neratinib, capecitabine. So I think any of those 3 options are fine. Neratinib does have more diarrhea associated with it. So my top 2 options in the third-line setting are DS8201 or tucatinib-based therapy. and I use the presence or absence of brain mets and prior therapy to help me determine which way to go. But it's certainly, I think this is going to evolve as the phase 3 studies begin to query proper sequencing and combination strategies that haven't yet been reported. And then the last thing was how to manage a patient who has what looks like ILD developing in the setting of being on trastuzumab deruxtecan. The patient's disease is responding, but there are ground glass opacities, and you certainly need to stop trastuzumab deruxtecan, even if the patient's asymptomatic and you see possible pneumonitis based on ground glass opacities. Consult with pulmonology, get a COVID test, consider steroids. This can be a fatal reaction to DS8201, so it's important to be very cognizant of that. So in the interest of time, I know we could talk for another hour, and I would love to do so. You guys are so wonderful and interesting to listen to with such a wealth of data. But we're going to just move on and close the program now. Remember to receive CME CE credit. Click on the Evaluations tab to complete the post-test and print your certificate. If you want to claim this activity as CME for MIPS improvement activity, follow the steps described on this slide. Thank you again, Shanu and Michael. It was such a great discussion, and thank you, our audience, for all the great questions you sent. I'm sorry we couldn't get to them all. We hope you'll be able to use these strategies that we've shared in your respective clinical settings. If any of your colleagues missed today's program, it'll be archived at cmeoutfitters.com, along with other resources such as animation that you might find useful. So if you need to go back and look at some of those slides that were so data dense, you are welcome to do so. Thank you again for participating, and thank you for providing the best care to patients.
Take care, everyone.
Thank you.